Hi, I'm Catherine Bertram, Senior Social Behavior Change Advisor with Johns Hopkins Center for Communication Programs and the READY Initiative. This session covers the principles of supporting community-led responses with vulnerable populations. So in this session, we'll explore the principles of risk communication and community engagement in humanitarian settings, while briefly reviewing the challenges in the COVID-19 response and providing guidance for planning local solutions with communities. I hope that by the end, you'll have a better understanding of these principles and the basic steps of engaging refugees, migrants, internally displaced persons, host communities, and other vulnerable populations in low resource settings. The content for this presentation is drawn from two guidance documents. So the practical guidance for risk communication and community engagement for refugees, internally displaced persons, migrants, and host communities particularly vulnerable to COVID-19 pandemic, and an interagency guidance document titled Finding Community-Led Solutions to COVID-19. So what are some of the challenges related to COVID-19 in these contexts? I won't spend too much time here because I'm sure many of you are already aware of many of these challenges, such as population density, poor housing, limited access to water and sanitation, overstretched or inaccessible health services, and widespread poverty. So all of this increased the risks and the impact of COVID-19. So let me just highlight then a few examples from this slide. Related to livelihoods, many people in humanitarian settings are employed in the informal sector, such as trading goods or driving motorbike taxis. And so they have no opportunity then to work from home or be paid when not working. With limited social safety nets, people may be forced then to break physical distancing and quarantine rules. So health systems, availability of formal health providers is low in many settlements. There are multiple barriers preventing access to quality healthcare, from cost to poor experiences of care in the past, and preferences for traditional healers. For example, in the Rohingya camps in Bangladesh, the IOM recently reported a 50% reduction in visits to health facilities and an uptake in traditional medicine. What about transient populations? So frequent movement can make it challenging for contact tracing teams to regularly follow up on contacts of confirmed cases, and this can lead to the importation of COVID-19 to new areas. Contact tracing teams may also not be trusted by some communities. So this is why it's important to integrate risk communication and community engagement principles into standard operating procedures for all response areas, including contact tracers. So what about the challenges with risk communication and community engagement programming? Again, I'll highlight a sample from this slide. It includes language barriers, of course, because humanitarian settings host persons from diverse countries who speak multiple different languages. There's also limited access to internet and phone in some areas. Social cohesion is sometimes an issue. So residents in camps and informal settlements often are from different backgrounds and different cultures. And then there are pockets of wealth and deeper pockets of marginalization. All of this can add to social tensions and impact on people's willingness to work collectively. In one case, humanitarian actions were focused on IDPs in the lowest wealth quintiles, and this raised a lot of concerns and complaints among displaced persons in those middle or higher income levels who are also feeling the devastating effects of COVID-19 and the response measures. There's also congestion within camps and informal settlements, making organizing any face-to-face risk communication and community engagement activities challenging, as it's hard to maintain physical distancing. We also need to make sure that our activities are not actually increasing the risk of stigma, as many of these groups are already stigmatized. And this is an issue that we need to be keenly aware of. So here's some guidance for planning local solutions with communities. So first, we need to understand the community and the context. So often this means carrying out an assessment, including a community mapping to understand community structures and those power dynamics, those beliefs and those community level capacities, those trusted and preferred channels of communication and sources of information. Importantly, we need to check first what data already exists because we're well into the response now. But if we're carrying out an assessment, this should be community-led so that it can tap into that local knowledge and the skills and then build ownership of the findings. So of course we can hold a meeting then first with community representatives to get their permission and guidance on the best way to carry out the assessment, and then work with those local groups to collect the data. Assessment should allow time for open conversations so that we're not just relying on the survey questions alone. So based on assessment findings, we can identify which leaders, community groups, and representatives we need to meet with to start planning local solutions. So there may be many groups that we can meet with that include refugees, IDP leaders, faith leaders, health workers, and groups such as women's groups, groups of community health workers, and people with disabilities. It may also include gangs, LGBTQ community members, youth groups, social protection groups, advocacy groups, local authorities, and police. You'll see a fuller list in the guidance document titled Finding Community-Led Solutions to COVID-19 that was referenced at the beginning of this presentation. You can also refer to the community engagement session in this module for a more detailed step-by-step process of engaging communities. So what kind of prevention measures can you discuss with these communities? So importantly, physical distancing. We can discuss with leaders and groups ways to encourage non-contact greetings between residents. We can talk about options for reducing physical contact in shops, restaurants, markets, and ways to reduce the flow of people in busy places at busy times. So for example, we can establish those one-way pedestrian systems, painting markings on the ground where people queue, or organizing tables and chairs in places where people eat to allow for safe distances, prohibiting standing in groups, or staggering the different times groups can leave their homes or access communal facilities. So you'll see an example of how communities came up with their own physical distancing solutions in Goal's field-based example in this module. So hand washing, you can work with leaders and groups to increase the number of hand washing facilities and encourage more frequent hand washing among residents. We can support groups to build and install hand washing facilities in key locations with supplies of soap and water. Key locations could be water pumps, latrines, transport hubs, markets, and places of worship. I refer you to the WASH IPC module for more guidance and examples. So religious and burial practices also can be discussed with leaders and groups to find acceptable alternatives. So that could be, for example, radio or online. Maybe just a note about transport, as there's a reliance on public transportation, and this could be an area for transmission. So we can discuss, or communities can discuss with public transport operators how they can reduce risks. So for example, by limiting passenger numbers to allow for more distance between people, keeping windows open to allow for better ventilation, and requiring passengers to wear face masks. Isolation of cases or suspected cases of COVID-19 can be difficult in crowded settings where many people live in one dwelling. And then especially if government facilities are not sufficient or if they're feared. So we can work with community leaders to identify local options for isolating people who have tested positive from the rest of the population. If people are separated, we need to ensure that people's basic needs are being met during quarantine and that caregivers receive personal protective equipment or PPE. It's also important to ensure that we're discussing the impacts of COVID-19, such as mental health or lost income, food aid needs, and how those can be addressed. Always consider the prevailing gender and cultural norms and the impact that any local solutions to managing COVID-19 will have on women, children, the elderly, people living with disabilities, for example. Ensure protection measures don't increase the risk of violence, including sexual or gender-based violence and violence against children. Violent enforcement of measures is not justified under any circumstances, and this should be clearly communicated. So let's take a look at an example. In DRC, Red Cross volunteers supported communities to produce locally designed portable hand washing stations. They did this with household water jerry cans that communities already use for collecting and storing water. They simply cut a small hole at the base of the jerry can and inserted a plastic tap. And these are easy to find in the local markets. Communities are now constructing their own stations and washing their hands more regularly. You can find more examples in the WASH IPC module. Once local solutions are agreed upon, they need to be communicated to the population with opportunities for people to ask questions and provide feedback on potential challenges. Trusted community leaders and community health workers, influencers, role models, and groups should all be supported to lead the response in their community. This also might mean training and enlisting the support of essential workers such as pharmacists, market vendors, gas station attendants, and frontline workers who have regular contact with people and can help share important COVID-19 information and other information related to the impacts, like other services. We can consider collecting testimonials from people who have recovered from COVID-19 to act as community champions and address rumors and misinformation. Faith-based leaders can be instrumental in providing messages, as these can also be trusted sources of information. Again, we need to ensure people know about support services that are available to help them manage the wider impacts of COVID-19, such as loss of livelihoods, food insecurity, access to healthcare, and other needs. Rumors and misinformation travel fast and could quickly undermine risk communication and community engagement efforts and lead individuals to adopt ineffective prevention measures, increasing the risk of infection and decreasing the impact of your response, whatever it may be. There's more about community feedback and rumors in the community feedback session in this module, which was adapted by Ready for IFRC, but maybe I'll just quickly review here. We need to establish a system for feedback, rumors, and misinformation if one's not already established. We use trusted channels and people within the community to collect community feedback and review these approaches. We should be discussing community feedback and how to act on it with the communities. And then update community members on how their feedback has been used and acted upon. Importantly, we need to make sure that we're addressing the fear, misinformation, stigma, and rumors quickly. So just a note about messaging for COVID-19. Though these general guidelines can be applied in any outbreak context, so I'll highlight just a few. It's important that specific messages be developed to target key population groups, such as adolescents, for example, who may have more social contacts, or the elderly who are more at risk of serious outcomes, or those who have influence over people's health behaviors, like in many situations, men, older women, traditional and religious leaders and healers. We need to acknowledge the challenges people face complying with the measures. So for example, telling people to physically distance when that's impossible in some situations will only lead to frustration. So we need to acknowledge those challenges while facilitating with the community's alternative solutions. Messages need to be clear, simple, practical, specific, and locally contextualized in local languages. They need to clearly explain measures in each community, so why these measures are being implemented and for how long. As we know, health illiteracy is a real challenge in some areas. And there's a real lack of understanding of what a virus is. So messages can focus on building people's understanding of how the virus transmits so that prevention measures then make sense. Importantly, we need to link to available services and resources. So those messages need to link to those services and resources. In many contexts, as we know, people are feeling the impacts of COVID-19 and the public health measures. So those messages should provide details of social safety nets to counter the impact of lockdowns. Importantly, we need to make sure our messages don't contribute to stigma, but then highlight the importance of social responsibility. So I hope you enjoyed this session and understand the basic principles of risk communication and community engagement, and explain the basic steps of engaging vulnerable communities during COVID-19 with community-led solutions. For more information, refer to the guidance documents referenced in the beginning of this presentation, which can be found on the Ready RCCE toolkit under community engagement. The WASH IPC and community health programming modules also include examples of engaging vulnerable populations during COVID-19. I hope you agree that community engagement needs to play an essential role in all of our responses for a greater impact. Thank you.